now the failed back surgery syndrome, our study, and that's the evaluate and report the causes of the failed back surgery syndrome and its risk factor. In our study, we do our study in Al Kuwait Hospital in 2010 and 2011. We focus on the lumbar surgery, and the definition of the back failed back previous the first second the previous one. Okay, the spine surgery basic. You can move the previous one. You hear me? Yes. The basic surgery of the spine surgery is basically accomplished only by two things. Number one is decompression of the nerve root and neural decompression from the pinch agent. Number two, stabilize the painful joint. So any patient complaining of back pain or same symptom or didn't improve from the back surgery, mostly he has no adequate decompression for the neural element or didn't stabilize a painful joint or micro instability issue. Next, please. Next. Yes. There is a predictability of pain after surgery. We can suspect the patient if it is relief from surgery simply from discectomy or, for example, if the patient become only leg pain, and he underwent lumbar surgery for this leg pain, mostly it is high successful operation in comparison to the other back surgery doing for the only lower back pain or fusion surgery. But actually, most patients will be improved for fusion. Next page. We do our study. This is the first paper in our study. We study the age group. We see that the peak incidence of our study is the fifth decade of life, about 41%, followed by the sixth decade of life, and decrease gradually. Next page, please. About the next column, we see the male predominance in our study, 55 in comparison to the female patient, about 34%. In the next column, we see the distribution of first symptom from previous operation. It was the both in our incidence. The peak was both leg pain and back pain, followed by back pain. The both patient complained leg pain and back pain was 72%. In the next page, distribution of the diagnosis in the first operation. We see that the most incident is the simple herniated disc, because there is a different entity. There is a lumbar disc and there is other entity different. It is lumbar degenerative disc. This cases we see the diagnosis in in the most incident is the herniated disc, followed by instability from the degenerative disease lumbar disc. In the next slide, we see the first operation which done for the operation in the first operation. It was the laminectomy and discectomy about 65, followed by simple laminectomy 70, because most of the patients have degenerative canal stenosis and osteophyte in the facet. In the next slide, we see the improvement after the first operation. The improvement of the very first operation of the patient was good in about 65 and very good about 10% of the operation. And in the next slide, about the first onset of the pain post-operative, it was early, it was late after about 1 year, within 10 to 12 months, followed by early 37. The early failed back syndrome mostly belong to the cause of wrong level or inadequate neural decompression in the intraoperative technique error. About the daily activity in the next slide, the daily activity, it is negative impact in the daily activity and doing work for the patient. which put the patient in critical situation to lose his job. About 55% of patient it is affected his job. About the next slide, please. This is the distribution of first operation. Okay, we see in this column the distribution of the first operation of the patient. We see that the big incident was in the laminectomy with discectomy, about 65%, because most of the patient was elderly and the fifth decade and have a degenerative canal stenosis, so underwent laminectomy and discectomy. Other big incident is 70% regarding to the laminectomy. In the other column, we see the distribution of the improvement. Most of the patients have good improvement, about 65%, but less percent have a very good improvement. In the distribution of the first onset of the symptom is the big inside 48% was the rate of some a couple of months, about 1 year the patient come again and complaining of the same symptom, followed by the early. The most of the early felt back syndrome mostly to the related to the inadequate neural decompression or long level. Regarding to the activity and daily activity of the patient, actually about 55% have a negative impact in his work. It is harmful to the patient to the lose whole job and extra. About the distribution of the causes of the analysis of our study, we see that the most incidence is 20% regarding to the instability of the spine, because most of the patient with degenerative cancer in the fifth degenerative lumbar disc disease and the fifth decade, post-operative has instability regarding to the micro instability or spondylolithiasis, followed by 70% regarding to the recurrent disc in the other level or long level. The wrong level here can be simply avoided by take a lateral view X-ray intraoperative. Better to do this to confirm the level of the disc intraoperative after the doctor do muscle dissection unilaterally before the start phlemotomy or laminotomy. He can take a shot of a screen before start and proceed his procedure of discectomy to confirm the level. About the diagnostic study, we do the 55% underwent CT scan. CT scan is to see the more bone detail anatomy and see the extension of the previous operation, or how they do the laminectomy or laminotomy or pharotomy, and the extension of bone removal is best to do to see by CT scan. The management of the patient with failed back syndrome in our study was 37 underwent a conservative and get improvement. About 62, most of the patient was underwent redo or surgical again. About the improvement after surgery, most of the patient improvement about 52%. What is recurrent or repeated surgery is very difficult from adhesion and scar and attached to the dura and high risk of CSF leak, and must be explained for the patient about CSF leak and nerve injury or something which is can be simply avoided by high technical surgical technique. In conclusion, in our study, we see that the prevention, the old word in the past, prevention is better than cure. So the doctor must be select and hyper select his patient and proper surgical planning and procedure along with the history and detailed history and physical and radiological findings. Tamam. We conclude that the prevention is better than cure. The physician selection of the patient and proper surgical planning along with the history and examination and radiological finding is do a lot to prevent a negative consequence and economical and psychological impact in the patient. In the last slide, if the doctor didn't find clean and strong causes of the patient pain with radiological finding that and the radiological finding didn't match the clinical symptom of the patient, the surgeon must be avoid the surgery and pay attention to clarify the causes of the symptom. So review the clinical and history and the examination and the radiological facility as X-ray, CT, MRI to avoid the risk of failed back surgery syndrome. Thanks.
Thank you, Dr. Abdurrahman, for your informative and very nice lecture, and which we face too much in this type of surgery, which is failed back surgery. So, what is the, in conclusion, in your experience, how we decrease the percentage of failed back surgery? You hear me?
Yes, Dr. Khalid. You hear me now?
Yeah.
You hear me?
I hear you.
Okay. In conclusion, that the most proper selection of the patient and proper history along with the examination and the radiological finding and more detail about the radiological finding, you see the X-ray, there is simple AP X-ray, there is oblique X-ray to see the bars, there is dynamic X-ray if there is instability of the patient. Also, we in the MRI finding anatomy, we must be to clarify the neural foramen and offending agent, and also to clarify that if there is canal stenosis, and we do proper surgical technique. For example, we must do a minimal invasive as we can. If the patient, for example, we only left leg pain, we do on the right side only. We didn't open all the interspinous ligament and remove the spinous process. We narrow our operation technique to the patient symptom, and we must be minimal invasive, and also must be respect and care about the bars. Don't disrupt and don't fracture the bars or the facet, because this is put a negative impact in the spinal instability in the future, in the short term or long term. So must be the preserved bars as you can, as we were. Otherwise, if your bars is fracture, must be put a fusion in an option in the operation.
Okay, thank you so much, Dr. Abdurrahman. You know this who beside me?
لا.
دكتور سعيد
دكتور سعيد.
حياك الله دكتور سعيد. Good morning.